Hey guys, and welcome to episode 111. And in this episode, I was honoured to chat with Dr. Edna Foa. For those of you who aren't aware, Edna is one of the most prolific OCD researchers there's ever been. In fact, the IOCDF, so the International OCD Foundation, in 2011 awarded her the Outstanding Career Achievement Award for her contribution to the field of OCD. She's also done a lot with PTSD research, post-traumatic stress disorder, and in 2010, Time magazine named Edna one of their 100 most influential people in the world. So, I mean, those two awards alone give you the impact she's had, grinding away, working hard, making a difference to people's lives, and I have the utmost respect for her work and for her dedication and just her passion for life. Edna gave a real kind of history of behavior therapy, ERP. That was really fascinating for me. We talked a lot about research in the last 20 years, what's happened, how it's changed. We talk about PTSD and OCD if someone has two of them, or both, which one should be treated first. I ask her about is there an association between treating OCD and PTSD? With the growing popularity of mindfulness-based therapy, has the emphasis on ERP dwindled, or is it still as strong as ever? We discussed many other things, but I really enjoyed talking to Edna, and I loved her advice for when I asked her about the good life question at the end. It's something I've put into my own life since. So I think you're going to enjoy this. Again, thanks so much to Edna for coming on, and I hope you enjoy. On the show today, I have Dr. Edna Foa. Edna is a professor of clinical psychology and psychiatry at the University of Pennsylvania and director of the Center for the Treatment and Study of Anxiety. She has devoted her academic career to study the psychopathology and treatment of anxiety disorders, primarily OCD, PTSD, and social phobia. In 2010, Time magazine named Edna one of their 100 most influential people in the world, and in 2011 she was awarded the Outstanding Career Achievement Award by the IOCDF. Welcome to the show, Edna.
You're welcome. Thanks for inviting me.
No, it's my pleasure. It's good to have you. I recently completed a master's here in London, and I was doing a systematic review on OCD, and your name came up time and time again. So it's really good to get you on. Okay, so the first kind of question is, I guess, your research story. So, what got you into studying OCD and PTSD?
Well, I started with OCD, actually.
Yeah.
And what got me to be interested in OCD is that when I was a postdoc at Temple University, just after I finished my PhD, the first patient that I had was a woman that had very, very severe OCD. Probably the most severe in some respect that I actually ever had. And her OCD symptoms was that she felt contaminated by everything that had to do with death. Not that she was afraid of dying, but like, say, cemeteries, flower shop, because people that go to cemeteries are buying flowers to put, on the graves.
Yeah.
Stones or anything that came from a cemetery. And in fact, everybody was contaminated because you never knew who touched whom. And, and everybody could have touched somebody who was in the cemetery. And so by generalization like this, she ended up being bedridden, and she even couldn't wear clothes or nightgowns because they were contaminated, and she couldn't touch anything around her. So she was naked in bed, and there was, she had a cover on her, a light cover. Her husband brought her to work in the clinic that I worked with Joseph Wolpe, who was an expert in anxiety disorders. And so he brought her to get treatment. So they were in the hotel, maybe 10 minutes away. And my job was to go every day to the hotel and treat her. And at that time, we didn't do EXRP or ERP the way we're doing now. At that time, we did systematic desensitization, which meant that I had like a stone that I took from a cemetery, and I would bring the stone, a small stone. Yeah. I would bring the stone and put it far away from her, and then get a little closer and a little closer and a little closer and a little closer, and she, and it maybe took 2 weeks until she were willing to touch the stone. And then I would bring something else, I would bring a flower, right, from a flower shop. That would take another 2 weeks. So at that time, we started to feel that she will never get better at this rate. And that was I'd say that this was like 40 years ago. Yeah. And at the same time, there was a treatment that was called flooding, meaning to go very fast, and do exposure to contamination or to anything that the person felt afraid of much faster. So we decided to go much faster. And actually that kind of worked with her. And we even I got her to go to a funeral home and touch things from funeral. And she got much, much better. Except that when she came home, she lived in Virginia, she relapsed. And when she relapsed, she decided that she wanted to do brain surgery for the OCD. Yeah. And she tried twice, and that didn't work. And then she came back to do the ERP. And so she was a very, very difficult case. And I got very frustrated, and that really raised I decided I'm going to be an expert in OCD.
Okay. So you like the challenge?
Again, and I also like to understand, because OCD people are a bit different from anxiety disorder people, like in the sense that the contamination travels, and that it's not like if you are a simple phobic or specific phobic and you are afraid of a dog, then if somebody takes the dog out of the room, then you're fine. Yeah. But if you are an OCD who feels contaminated by a dog, and somebody takes the dog out, the contamination stays behind.
Yeah.
And,
sorry, go on.
That's very different. And then you need to clean. And then comes the rituals. So it's not just avoiding things, it's also the rituals, the active rituals. Then you need to clean, or you need to check, or you need to put things in order, or you need to put things just so. And that in that way, it's not It's different from panic disorder. It's different from specific phobias. It's different from social phobia, and that's very intriguing.
Yeah, thank you for that. I've never heard it described in that way, or even thought myself that, yeah, it's very different from a specific phobia in the sense, as you said, if you take the stimulus out of the room, for example, in the dog phobia, effectively they're fine, anxiety drops pretty quickly. Obviously, as you said, with OCD, it's still going on inside their mind.
Right. And the same is like, why is it that a person that checks all the time, right? They check the door, and they try the door, and the door is locked, and they go a few steps, and they say, "Did I check the door?" And they go back to check, as if something is wrong with their memory.
Yeah.
But we don't see that there is a general memory deficit. So what is going on?
And we still don't know, do we? Is that correct?
No.
Okay. Yeah, no, that's interesting. Thank you for that. And thank you for explaining the story that kind of got you into it. So my next question is basically, therapeutic outcomes in ERP are very good for OCD. To me, which begs the question, is there such a thing as treatment-resistant OCD? Or is it more to do with, say, the therapist or the way in which ERP is being delivered?
Well, the majority of patients with OCD that get exposure and response prevention or ritual prevention are doing better. Some do, quite well. Some do less well, but the majority do. They do gain. On the other hand, I would say that it's rarely that I see an OCD patient that is completely cured of the OCD. There's always some residual for the most part.
Yeah.
So we're doing well, but with PTSD, for example, you have at least 40% that are, we can say, they're cured. They are totally in remission. They said, I don't have PTSD anymore. Okay. Definitely, with specific phobia, well, I'm not afraid of dogs anymore.
Yeah.
And we don't much see it in OCD. So the question is, why, what is holding them back from just giving it completely up? I remember one of our, star patients that was quite severe contamination, and also she had checking rituals, but mostly contamination, and mostly she was very sensitive to being contaminated in her hair. But she did really, really well. Went back to work, and I interviewed, when I wrote the book Stop Obsessing. Yeah. I interviewed her for the book, and I asked her, "You are cured, are you? I mean, you're one of the people that rare people that I can say that you're completely cured." And she said, "No, that's not true." I said, "So how do you know that you're not cured?" And she said, "Once in a while, I brush my hair, in the morning, before I go to work. And then the brush falls on the floor. And then I get a panicky feeling, oh my God, what am I going to do now?" Right? And so then I pick up the brush and I brush my hair without washing it or anything.
Yeah.
And I throw it back on the floor. And I brush my hair again. I pick it up and I brush my hair again several times until the panicky feeling is gone. Kind of doing exposure.
Yeah.
And that she said, this is the way I know that I'm not cured. It can always come back, but I don't allow it to come back because I immediately take action.
Yeah, I love that. That's a really good attitude. And that kind of ties me into my next question, which is kind of what are the key characteristics of your most successful patients that when they approach treatment? For example, like the lady you just described had that kind of, I don't know how you describe it, but just a real upbeat, proactive attitude of repeated exposures when it comes back and not kind of worrying about it so much, but just doing what she knows.
Actually, she also was quite depressed in the beginning.
Okay.
And she really battled, it was really, really difficult for her. But, she was so motivated to regain her life. And I remember that she was, doing, the exposures, not washing hands, and tears came down, from her eyes, but she was insisting of doing it. So there was determination.
Yeah.
I'm not going to let the OCD control me. I'm going to control the OCD. So I think it is a determination. Well, in some way, people that decide I'm never going to smoke again.
Yeah.
And I'm not going to let cigarettes kill me. I'm not going to let the OCD ruin my life.
Yeah, making a choice, like a firm choice.
It is a choice, and I mean it's not a choice that come easily. I mean there is struggle. It's not that they come and you say, and they said, I want to get well, and I'm going to, and there is no, there's no struggle. They do exactly what you ask them to do, and they kind of progress, according to the program, with no setbacks, with no issues. That doesn't happen.
Yeah. Okay. So no, thank you for that. You touched on determination there. So I noticed you did a study in 2008 on motivational interviewing and how that can boost adherence to ERP. Is that, I guess this maybe is a question for my therapist listeners, is that something you recommend them bringing into their ERP treatment?
Actually, this study was done by Blair Simpson and myself.
Yeah.
And she was the first author on it. And we didn't find any motivational so that there was a group that got motivational interviewing plus EXRP. And another group that got EXRP, without motivational interviewing, and there was no difference.
Okay.
And I think there's no difference because we are doing motivational interviewing all the time. I mean, as we do, the exposure, as we do the response prevention, we give them a lot of compliment, reassurances. I mean, not reassurances that nothing will happen to them because that's not a good thing. When you do EXRP, you said you take the chances and you see if it works or not. Because they said, well, if I sit on the floor and I don't wash my hands and I don't take a shower, I'll get sick or I'll make my children sick. And we said, well, how are we going to learn that this is not the case? Or the probability is very low. And so only by doing it, only by sitting on the floor and by not washing your hands afterwards or not taking a shower. And then you don't take a shower for a day or two, and then you find out your children are not sick.
Yeah.
Right? And so, we do a lot of talking to them, a lot of increasing their motivation.
Yeah, you're right. You naturally do it as part of the program.
It's part of the program, and so that's, I think, why we didn't find that adding motivation and interviewing is helping, because we're doing it anyway.
Yeah, true. It's very much part of CBT generally, right?
Right.
Yeah. Okay. No, thank you. So this is more of a general question, and it's quite broad, so feel free to answer it however you wish. It's basically, what have been the key areas of research for OCD treatment in the last sort of decade or 20 years?
I actually am not sure that we made huge amount of progress. We added cognitive therapy.
Yeah.
And I don't think that the research shows that if you add cognitive therapy, and discussing, convincing the patients, to give up unnecessary responsibilities, sense of responsibility, is actually helping more than ERP or EXRP alone. So I think we are. We are in the same place, more or less.
Yeah. Okay. So I mean, that's good and bad, right? But I mean, good in the sense that it was already pretty effective from like 30 years ago. So how has the research, or what have we learned about ERP, like say now compared to 20 years ago? Have we learned more around ERP specifically?
20 years ago, I'm not sure we learned a lot, but from 40 years ago, yes. We used to, originally, with exposure and response prevention, we used to hospitalize people. And the first article by Victor Mayer was in 1966. And he hospitalized two patients with washing rituals. And they didn't have water in their room. So they didn't have access to water. They can just, clean themselves once a day. Take a very quick shower once a day. And I think they were in hospital, if I remember correctly, like 6 or 8 weeks. Now we learned that, first of all, for the most patients, we are doing outpatient and not inpatient.
Yeah.
And we learned that we could do it much faster. And we learned that we can do the response prevention. I mean, we don't have to stop the rituals all at once like we used to do.
Yeah.
Then we can do it gradually. So maybe, like you take a shower 40 minutes and, then 35 minutes the next day, and then, 30 minutes, and you get to 10 minutes.
Yeah.
Or, you get to wash your hands for 2 seconds 5 times a day. But you get it gradually. You don't have to be so severe. And we also learned that, that we do the exposures, not not very, not like systematic desensitization, like I described with my first patient, that it takes you 2 weeks to get attached the stone, from the cemetery, but we go much faster. But still, we do go by hierarchy.
Yeah.
So we start with things that are upsetting the patient, maybe 50 from 0 to 100. You don't want to start from very low 10, because that will take a long time. So we know that we can go faster.
Okay. Yeah. Thank you. That's no, that was very useful, and again, I like the kind of history around it. I've seen that study, but I haven't actually read it. I need to. So the next question is, for someone with OCD and PTSD, is there or does the research show which should be treated first, or can they be treated simultaneously?
Well, there is no research that is asking this question, but I think clinical wisdom is saying that you would like to start with what makes the patient more upset. So, like if the OCD is more severe than the PTSD, you want to start with the OCD, because, this is, they will gain more if we will start with the OCD, and then move to the PTSD, then vice versa. But also clinically, we see that doing both treating both the PTSD and the OCD at the same time, it's too difficult for the patient. So we want to start with the diagnosis that it's more severe, to get the person's relief, and then move to the second problem. We also find that if we treat the OCD, it doesn't usually affect the PTSD. It doesn't transfer, and vice versa. So you really have to treat both.
Yeah. Okay, no, that's interesting. So kind of two-time guest to the show, Dr. Stephen Phillipson. When I said I was getting you on, he had a few questions for you, and he said you're the queen of OCD, so quite a compliment.
Thank you.
The first question he wanted to know is, and I guess you somewhat answered there, which is there an association between treating OCD and PTSD?
Well, in the association is that in both of them you're using exposure. So in PTSD, you use exposure to situations that person is distressed because they are related to the traumatic events and also you do emotional exposure to the traumatic event with PTSD, asking the patient to recount the traumatic event repeatedly until they feel more comfortable, and until they find out that they're not falling apart, that nothing bad happened to them, that they stronger than they think they are. But the exposure is common. So with the OCD, you do expose them to mostly to in vivo exposure, that is to life situations. Like leaving the house without checking the doors, leaving the kitchen without checking the stove, in contamination, sitting on the floor and not washing yourself after that. In ordering is leaving the house in a mess and not ordering, that's an exposure. And less often you use imaginal exposure, which is, and sometimes you ask the patient to imagine what will happen if they didn't wash.
Yeah.
I mean, so the children get sick, and it's all their fault, or they drive a car and they think that they feel that they are driving on a bump, but they don't stop, and then it turns out that they actually they injured a person, and so now now the police is after them. All those things that they're afraid that will happen, but they don't happen, and you don't want to make them happen in reality, right?
Yeah.
And what they learn is several things. They learn that thinking about those things doesn't mean that they will happen.
Yeah.
That thinking is not doing. That thinking is not, imagining doesn't mean that it really happens.
Yeah.
And that's very helpful to people with, to OCD patients that have fear of bad consequences if they don't ritualize.
Yeah, no, I really like that. That was a good explanation. Thank you. Yeah, because I think that's the toughest one. So for someone with OCD is, the feeling that this bad thing, whatever it is going to happen. And I guess with imaginal exposure, you can kind of give them the opportunity to see that link that thoughts don't equal reality necessarily.
That's right, and that thinking about it doesn't make you a bad person.
Yeah, absolutely. Okay, so Stephen's next question for you is, with growing popularity of mindfulness-based therapies, do you believe that the emphasis on ERP has been reduced, and is that favourable to treating OCD?
Can you repeat the question?
Yeah, no worries. So Stephen wants to know, with the growing popularity of mindfulness-based therapy, do you...
Mindfulness?
Mindfulness.
Mindfulness.
Yeah,
so
sorry.
I didn't get it right.
No, this is home on board. And he wants to know, kind of, with the rise of that, is that decreasing the importance on ERP, or is that not the case?
I don't know of a study that did mindfulness with OCD and comparing it to EXRP.
Yeah.
So I don't think that we have a better treatment at this point, a treatment that is more effective than exposure and response prevention.
Yeah, I agree. There are some studies on mindfulness and obviously ACT and things like that, but the problem is they're rarely randomized controlled trials, and they rarely can put themselves against exposure and response prevention. But yeah, I agree that all the evidence is there for ERP. This next question. So, is it true that everyone in Israel has to do a year in the army?
Well, yeah, I mean, more than a year.
Okay. But did you have to do more than a year?
No, I actually didn't. Okay. Because, I deferred and then, and studied, and then I got married, and at the time, married women didn't have to go to the army.
Yeah.
But also, you have to be healthy. You have to have good mental health. I mean, some people are not. Not everybody is accepted to the army.
Okay.
But if you are healthy and you have, your mental health is good, you have to go to the army.
Yeah. Okay. No, thank you for that. Because the first part of the question was, he wanted to know, did Edna's training in Israel's army, which we now know you weren't in, did it influence your intensive ERP approach for OCD, so the sort of intensive sort of week approach as opposed to weekly sessions?
No, it actually it had nothing to do with it, because the first studies that were done on EXRP were done in England by Isaac Marks, by Jack Ruckman, by Victor Mayer. At that time, all the treatment was intensive.
Okay.
The treatments were every day. For 15 weeks in the first studies. So as I said, they were also inpatient. Then they became outpatient, and then some treatment were every day, 10 days. But the intensive was the what was done at at the time. And then we actually, I think, did the first study that we compared every day, 15 session to twice weekly. And then we find, of course, that after 3 weeks, when we finished the intensive, the patient was much better than they were twice weekly, because in 3 weeks they had only 6 sessions. But when you go to the 15 sessions of twice weekly, there was no difference in outcome. And so we started to do twice weekly, and now we're doing once weekly. I don't suggest to do less than once weekly.
Yeah.
And I think what's really, really important is to be very structured, so that every session you do exposure and you do response prevention, and our therapists go out with the patients. If they're afraid of being contaminated by hospital, they go to the hospital. So we do a lot of in vivo exposure, in reality, both in sometimes you can bring the contamination or into your office, and sometimes you just go out. With checking, it's more difficult to do it in the office, because checkers don't so much care what happens in your office, they care what happens in their home. So there, we are using Skype now. They do it. They do it at home, or we go with them to their home to do it. To do the exposure, the response prevention in the places where they care, where they get upset.
Yeah, that's really good. I obviously know people do ERP through Skype now, but I never thought of the use of, obviously, like you said, if someone's compulsion is checking, and rightly so, it's usually in their home, then Skype's a great use for that if the therapist can't get to the person's home.
With Skype you can do a lot of things now that we couldn't do before, and you can have a session where the patient is, you are, giving instruction to the patient do things, right, and you're there with them, but you don't have to go to the home that often, which can be far away.
That's really good, and obviously it increases access for those that aren't near a treatment center or an OCD specialist.
Right.
Yeah. Okay. Thank you. So that's all of Stephen's questions. I have a couple sort of, I guess, non-OCD related, but in a way linked to OCD questions near the end now. So the first one is, you've got a billboard in Philadelphia. What would you want written on that billboard for the world to see?
With regard to what?
Whatever you like.
OCD?
It could be, or it could just be any kind of advice you want to give the world.
Well, I think that as a person who is specialist in anxiety disorders, I'd like to, and I know how many patients are suffering, that, I want to give the advice, if you're suffering from irrational fears, right, there is treatment. And CBT treatments in general are quite effective. So go and find help, but go and find help with treatments, evidence-based treatments.
Yeah, really good. Yeah, I like that. I might have to give you a few billboards for that message. So the next question is, and this is kind of advice from one human to another. What advice would you give someone if they asked you, how do I live a good life or a meaningful one?
It's a very difficult question.
Yeah, sorry.
But I suppose that you try to do what you like to do, as much as you can. On the other hand, none of us does only what they like to do. So when you have to do things you don't like to do, just accept it as part of life, and don't get upset with it.
Yeah, I like that. That's a good one. Haven't had that one before. So Edna, that kind of brings us to the end of the interview. I'd like to thank you for your giving up your time. I really respect the work you've done over the years in the field of OCD and PTSD, and appreciate you kind of sharing more wisdom on this show.
Thank you so much for inviting me to your show.
So there you have it. I really hope you enjoyed my chat with Edna. And if you enjoyed the show, please give it a like on Facebook and a review on iTunes or however you're listening to this. I appreciate the feedback. Quick disclaimer, this podcast is not therapy, nor is it a replacement for therapy. Please seek treatment from a trained professional, and I'll speak to you soon.